Hello, everyone, and welcome to our Community Conversations on Cancer. I'm Christina Hawes, the Community Engagement Coordinator for Community Outreach and Engagement Office at Wilmot Cancer Institute. I'd like to welcome you to today's webinar, Understanding Lung Cancer, How Our Body Clocks and Community Factors Affect Health. This features a presentation by Dr. Juliana Casarin de Meneses, the winner of the 5th annual CCAC Retreat fan favorite poster. So if anyone was at our retreat back in October, you should have seen this poster. So we're all very excited to have her. This webinar is part of our Community Conversations on Cancer series, an educational series designed to inform, educate, and disseminate best practices in cancer research, clinical care, and community engagement. It is sponsored by the Office of Community Outreach and Engagement, CIRTEC, and the Community Cancer Action Council, or CCAC. This live event has been approved for 1 AMA PRA Category 1 credit, 1 CNE credit for nurses, and 1 contact hour for social workers. If you'd like to receive credit for attending, make sure to fill out the post survey. The link will be provided when this webinar closes, as well as in a follow-up email. So our presentation today will be followed by a facilitated Q&A session. Throughout the presentation, please feel free to enter any questions in the Q&A box located at the bottom of your screen. Today's conversation will be a bit different from our usual conversations, in that we'll be talking about a few different aspects of lung cancer through 3 different presentations. With a lot to cover, let me jump into our introductions. First, Juliana Casarin de Meneses, sorry, I practiced too, is a postdoctoral researcher in Dr. Brian Altman's lab at the University of Rochester. Originally from Brazil, she holds a bachelor's degree in biomedical sciences and a master's in physiology from the Federal University of Rio de Janeiro. She completed her PhD in biological sciences in 2018 through a dual degree program between the Federal University of Rio de Janeiro and the University Paris Saclay Saclay, France. Sorry. Before joining the University of Rochester in 2021, Juliana was a postdoctoral researcher and lecturer in endocrine physiology at the Federal University of Rio de Janeiro. Her research expertise spans cellular signaling in tumor cells with a focus on oxidative stress, metabolism, and circadian rhythms in models of thyroid cancer and lung adenocarcinoma. Next, we will have Sarjona Srithran. Sarjona is a junior at the University of Rochester, majoring in epidemiology and statistics. She plans to continue her studies to receive a master's in public health and hopefully work as an infectious disease epidemiologist. And we will close with Angela Ganella. Angela works as the Lung Cancer Community Navigator Manager at Go2 for Lung Cancer. She's a licensed social worker residing in Rochester, New York. She has extensive experience working with patients impacted by cancer, having previously served as the Director of Clinical and Support Services at Cancer Support Community at Gilda's Club in Rochester. Since joining Go2, she's been instrumental in leading a regional demonstration project in New York to impact the uptake of lung cancer screening. So welcome to all of our speakers and to you as our attendees. I will now hand this over to Juliana to make sure that we have time to get through everything that we have set up for you today.
Okay, great. Let me just share my presentation. So hello, everyone. My name is Juliana, and thank you so much for attending this session today. So today I will be talking about the poster, the work I presented in the last CCAC entitled TikTok, Meek is on the Clock, investigating the role of meek on circadian rhythms and its impact on lung cancer. But before starting to talk about the project itself, I want to give you like a little bit of background on circadian rhythms. And circadian rhythms are about the capacity of our body to track time of the day. So in our daily lives, we track time of the day with our watches and cell phones and use that to organize like all the activities on your day in the best way possible, the most effective way. And our body also has means to keep track of the time of the day, and they actually use that. Oops. And your body uses that to organize our physiological functions, our biological functions throughout the day and night cycle, making sure that everything is happening in the right time of the day. So circadian rhythms are these natural 24-hour cycles observed in our biological functions. A good example of that is our sleep-wake cycles. So we are diurnal creatures. So we wake up, we are awake during the day, and we are sleeping during the night. And the time when we go to bed and the time when we wake up is highly regulated by our circadian rhythms. So what else is regulated by circadian rhythms? What else shows oscillation in a circadian fashion in our body? So most of biological functions, if not all, show circadian oscillation. So body temperature, heart rate, blood pressure, like hormone secretion is highly circadian. Many hormones that control the concentration of sugar in our blood, but also that controls like when we feel hungry, and also hormones that control when we go to sleep. They also oscillate in circadian fashion, our metabolism, feeding patterns, neuronal activity, even immune responses is regulated by circadian rhythms. And even at a cell level, like when our cells divide and when the repair mechanisms are taking place, are also regulated by our circadian rhythms. So the structure responsible for generating these oscillations in our biological functions are what we call our body clocks or circadian clocks. The circadian clocks, they're present in virtually like all tissues on our body and all cells in our body, actually. So what are the circadian clocks? So the circadian clocks, I will not go deep down on the system, but I just want to show you that the circadian clocks, they are like a network of gene and protein that regulate each other and work together to generate these oscillations in our body functions. The circadian clocks control a good amount of protein coding genes in every cell of your body in a very tissue-specific manner. And one interesting fact is that the initial characterization of the system was a breakthrough in science and was awarded in 2017 with a Nobel Prize in Physiology and Medicine. So our circadian clocks, our body clocks, they will generate these oscillations in our body functions, but they're also highly regulated by factors from the environment. And one important factor that regulate our circadian rhythms is our exposure to light, our daylight exposure. And this will be an important factor to tell our body clocks what time of the day we are. So these body clocks, they can align these rhythms to the day and night cycle. So what happens is that when we expose to light, these will be detected by some cells in our eyes, and these cells will send information to the central clock that is located in our brain. So the central clock, or this master clock, will work as a conductor in an orchestra and will send information to the peripheral clocks located in every tissue and every cell in our body, telling them, oh, it's day, it's night, just behave accordingly. So like that, all our internal body clocks will be aligned to the day and night cycle. So it's very important that all these systems work in harmony because the circadian rhythms, as I mentioned, they control a huge amount of biological processes in your body. And actually, circadian rhythms are super important to allow anticipation of expected environmental changes and to prepare our body like to the different challenges throughout the 24 hours, guaranteeing that we are like our body's working in the most effective way. So when these systems not working well, when our internal body clocks, they're not aligned to the day and night cycle, or our internal clocks, they're working in the different time zones, or they're not working in harmony between them, we have circadian disruption. And the circadian disruption, as we will discuss, seems to be detrimental to our health for different reasons. So before going forward, I want to discuss a little bit like factors from our lifestyle and modern life that could disrupt our circadian rhythms. So one of these factors is, for example, light and night. As I mentioned, exposure to light is a very important and very environmental cue that will be important to our internal clocks to know if it's day or night. And if we are exposed to light at night, we are kind of tricking our internal clocks, and this can lead to circadian disruption. A second important factor is night shift work. So people that work in night shift, they are usually working during the night where they are supposed to be sleeping and they are working during the day. Another way to disrupt our circadian rhythms is like jet lag when you travel between different time zones, and also social jet lag. The social jet lag is like the modern trend that where we have very different sleep schedules during weekdays and weekends when we are not working. So during the weekdays, because of work or school, we usually sleep like less hours and we usually wake up earlier. Earlier than our natural rhythms would tell us to wake up. But in the weekends, we usually wake up later because we don't have like social demands requiring us to wake up early. So, and this difference in the sleep schedules between like the days of the weeks and the weekends is also something that might leads to circadian disruption. The issue is that the disruption of circadian rhythms in the last 20 years has been associated with several diseases, including sleep disorders, metabolic dysfunction, infertility, psychological disorders, and also cancer. So now I'll talk more about what we know so far about the impact of circadian disruption and cancer. So in the early 2000s, some studies started to be published showing that night shift workers are at a higher risk of developing some cancers, mostly breast and prostate, but also other cancers as colon and lung cancer. So this was enough for the International Agency of Research in Cancer to establish the night shift is would be probably carcinogenic to humans. So this fostered a lot of studies that came after that, just trying to understand how it works and how circadian disruption would be having an impact in cancer incidence and development. So what we know from, I think, the last of 10 years of research is that many cancers, many human cancers have disrupted circadian clocks. So I showed you the picture of the circadian clocks before. That is that network of like proteins and genes that work together to generate the rhythms. And many of those proteins implicated in the circadian clock, they actually show like disrupted levels in cancers when compared to normal cells. On the top of that, in the last 10 years or so, a lot of animal studies came out showing that actually some cancers could benefit from disrupted clocks. So in these studies, what was shown is that when the animals are under circadian disruption, this would accelerate the development of tumors when compared with the animals that shows like a healthy circadian rhythms, showing an implication of circadian disruption in cancer development. So our lab is focused on understanding like three main points. So first would be what drives circadian disruption in cancer cells. The second, like which advantages cancer cells take from disrupted circadian rhythms. So why cancer cells proliferate more when circadian rhythms are disrupted. And the last one, of course, can we fix disrupted clocks? How could we use that to treat cancer? So we discussed about some ways to disrupt our circadian rhythms, and mostly related to our behavior and social habits, but we think there is more than that. So in the lab, we think that there are some features or some mutations in cancer cells that could be able to lead to the disruption of the circadian clock of these cells. And one potential candidate for that is MEEK. MEEK is an oncogene that is usually overactive in many human cancers. And MEEK, when it's overactive, it will induce the initiation and progression of cancers. The issue is that like our lab and other labs also showed that meat has the ability to impact or to interfere with the normal functioning of the circadian cycle in cells. So what we showed in a paper published last year uh, is that when meat is off, like many genes are oscillating in a circadian fashion in cancer cells in the dish. And when we turn meat on, 80% of these, 85% of these genes, they actually lose oscillation, showing that when meat is overactive, there is a huge impact on the circadian clock of these cells, which is characterized as a circadian disruption. So, what we think is going on, our hypothesis, is that when the meat expression is uh, out of control and when meat is overactive, this would lead to the disruption of the cancer cell circadian clock, and these would somehow contribute to cancer initiation and progression. So our research question is, how does meat impact circadian rhythms in lung cancer? And how does this contribute to tumor growth? So why we want to study that in lung cancer specifically? So first, lung cancer is the leading cause of cancer-related deaths worldwide. And in our catchment area, lung cancer incidence 30% higher than the national average. So it's also a local interest. And MEEK is usually overactive in a high proportion of lung cancers, which make it like a good model to study MEEK signaling. So before going further in the project, uh, I I would like you to give some contextualization of human disease. So before going deep to the characterization of MEEK on circadian rhythms and lung cancer, we did a little bit of research to understand if this would be relevant for human disease, of course. So what we did was to check some databases from patient data and observe if there is uh, any finding or any data that would suggest that alterations in circadian rhythms would be implicated in lung cancer beyond the epidemiological data that we already had. And what we found is that in lung tumors from patients, the expression of BMAL1, which is a major component of the circadian clock that I showed you before, is suppressed, which could be an indicative that this clock is not working well as the clock and normal cells. And we also observed that patients that show low levels of BMAL1, low expression of BMAL1, this is correlated with worse overall survival. So if BMAL1 is low in these tumors, usually the prognostic is worse and the patients will live less, like shorter. So the conclusion of that is that BMAL1 is suppressed in lung adenocarcinoma, which correlates with worse survival in patients. So what about MEEK? What MEEK is doing in this scenario? So what we also find is that apparently there is an inverse correlation of MEEK and BMAL1 expression in lung tumors. Here I'm showing to you a immunohistochemistry, which is a slice of lung cancer. And here we stain and we're measuring the levels of BMAL1 MEEK. And all these brown stains here means signal. So if you have like more brown stain, there is like higher expression of this protein. So what I see here in this sample one, for example, is that in this sample, BMAL levels are quite low. There's barely no brown staining here, but MEEK levels are high. However, in other samples, when BMAL1 is high, MEEK levels are low, showing that there is an inverse correlation between both. So when you have like high levels of MEEK, we usually see low levels of BMAL1. Of course, this is a correlation. We cannot imply cause and consequence in this scenario. We don't know if MEEK is actually driving suppression of BMAL1, and this would lead to a circadian disruption. So to study that, we have to use animal models. So in the lab, we have this model. It's a mouse lung cancer model where we can turn on and off the levels of MEEK in the lung of these animals. So if we turn on MEEK after some months, these animals will develop lung cancer. Okay. And we can turn it on and off according to the experiment. So what we did was, okay, let's turn on the MIC expression in the lungs of these animals and see what happens with the circadian clock of these cells. And what we saw is that when we activate MIC for only 3 days, which is still not enough to induce the formation of tumors, we observed that the levels of many of those genes involved in the regulation of circadian clock is suppressed, which could be indicative that the circadian clock of these cancer cells or pre-cancer cells are not functional. So to confirm that, we did a second assay. In this assay, we can track the oscillation of the protein levels of HER2, which is a component of the circadian clock. So in normal cells, in normal conditions here, when MIC is off, we can see that HER2 is oscillating throughout the days, which is normal because it's very circadian regulated. However, when MIC is on, we can see that in the first days, HER2 is still oscillating in these lung cells. However, after day 4, this oscillation is weaker and weaker. And this is also a sign that the circadian clock of these lung cells is affected by MIC, is disrupted by MIC. So with this data, we know that MIC induction in the lung of these animals is able to disrupt the clock of lung cells. So what else is happening in the lung in this time frame? As I mentioned, we still don't see tumor formation yet, but we already seen some events that will be important for the tumor formation that will help happen in the future. One of these things is that these lung epithelial cells, they usually don't proliferate a lot in normal conditions, but when an oncogene is activated as MIC, they can gain proliferative capacity, which is an early event implicated in cancer formation. So here in this staining, this immunofluorescence, we are seeing here the lung cells when MIC is off, and lung cells when MIC is on. And the increased amount of green staining means higher proliferation because they are incorporating this nucleoside analog. So if you have more green staining here, it means that when MIC is on, the cells are proliferating more. So the next question was, okay, but MIC can disrupt the clock, MIC is inducing like more proliferation in these cells, which it's a process implicated in cancer formation. But does this proliferative effect of MIC depends on the disruption of circadian clock? So in other words, like MIC depends on circadian disruption to induce this proliferative phenotype, this proliferative scenario here. And this is what we're trying to answer right now, actually. So what we did is that, okay, let's turn on MIC. And in some animals, let's try to restore the clock that is disrupted, right? And to do that, we use a drug that has been shown to increase a drug that increase circadian oscillation and make the clocks like show more stronger oscillation. So we turn MIC on and we analyzed the expression of Ki67. Ki67 is the gene that is usually increased when cells are proliferating. So the increased expression, the increased levels of these genes means more proliferation. So when we turn MIC on, there's an increase in the expression of this gene that is compatible and corroborates with increased proliferation I showed you before. When we turn MIC on, but when we try to fix the clock, this effect is partially reversed. So when we try to fix the clock, when we fix the clock actually, the levels of a Ki67 is not as the control completely, but they are not also as high as observed when MIC is active and the clock is disrupted. So this indicates that at least the circadian disruption might be playing at least a partial role on the MIC effects on cell proliferation. So the conclusions of that is that MIC disrupts the circadian clock of lung cells. The oncogene MIC also induces the cell proliferation in mouse lung cells. And the circadian clock restoration potentially attenuates some of MIC effects on cell proliferation. suggesting that MYC proliferative role might be somehow depending on clock disruption. And why we think that this project is important. So this is my last slide. I'm running out of time, but of course, our ultimate goal is to find new ways to target tumors and improve patient survival. And even though like we are still running these experiments in mice, and maybe the translation to human disease will take a while, the idea is that um, some tumors will show disrupted circadian clock, which we think that might accelerate tumor growth. So the idea is that if we can restore this clock somehow, like with drugs, for example, and turn this defective clock in a health clock again, maybe this could be enough or it could help to slow down tumor growth. And why this would be important, why we think that this project is important. I think that this project highlights that circadian clock is a potential therapeutic target for treating cancers. And also, our research may foster the development of drugs targeting the circadian clock. As I mentioned, we still don't have drugs in clinical use, and also even at research level, we don't have like a variety of drugs targeting the clock. So these drugs are not yet very specific. But if we show that the clock circadian rhythms are important, maybe this will foster the development of more efficient and specific drugs. So from a MYC perspective, it's important to mention that tumors with high MYC levels, there's no specific treatment to address these tumors. There's no drug targeting directly MYC. So maybe MYC-driven cancers that potentially have like a disrupted circadian clock, they could benefit from therapies targeting the circadian clock of these cancer cells. So this is what I've been doing in the lab. Please feel free to ask any questions. And now you're going to see the next presentation. Thank you so much.
Okay. Hello, everyone. I'm going to share my screen. Once again. Okay. So my project was a study of historically redlined districts and current disparities in lung cancer incidence and smoking in Rochester, New York. So some background on what we were trying to do. Smoking is a particularly pressing issue in Wilmot's catchment area, and 22 of the 27 counties in the catchment area, including our own Monroe County, have smoking rates higher than those of both New York State and the US. And unlike other parts of the country where Black and white adults have similar rates of smoking, in the Wilmot catchment area, Black adults have a prevalence of smoking of 27.5%. So they're more likely to smoke than their white counterparts who have a prevalence of only 16.9%. And the smoking rate among Latinos in this catchment area is also higher, 16.3% compared to Latinos in the US overall, which is only 12.3%. And as we talked about earlier, lung cancer incidence is 32% higher in the catchment area than the rest of the country, and mortality rate is 11% higher. So this disparity in lung cancer incidence between Black versus white men is more than twice as wide as the disparities seen in the rest of the US. So that shows that there is an urgent need to understand the mechanisms underlying the disparities in both tobacco use and lung cancer incidence overall in the Wilmot catchment area. Also, lung cancer remains the leading cause of cancer-related death among Black and Latino individuals. Neighborhood deprivation and area-level factors like education and income are generally associated with higher lung cancer incidence and mortality. And neighborhood deprivation has also been associated with increased tobacco outlet density, where the most deprived neighborhoods have the highest outlet densities, which could also be a contributing factor to tobacco-related disparities. So what was redlining and what did it entail? So from the 1930s to the 1940s, the federal government created thousands of area descriptions for cities across America, including Rochester. So it was first created by the Homeowners Loan Corporation, and it was then adopted by the Federal Housing Administration and the Veterans Administration. And they all used these to guide where it was safe to insure mortgages. So on this slide, you can see some direct quotes from these maps generated and maintained by the federal government for Rochester itself. And the degree to which these area descriptions portray the overt racism underlying these definitions is profound. So you can see like blatantly problematic descriptions in areas that are assessed as more desirable. Like in the green area, they say that they have a lack of sewage handling services and high rates of foreclosure. Whereas the description of areas that are assessed as more hazardous, so like the red areas, they're describing beautiful neighborhoods, but they're focusing on the encroachment of populations described in overtly derogatory ways. And you can see that in these quotes right here. So some of the, sorry, a second. So our objective was to assess the association between, to evaluate the associations between redlining and smoking and lung cancer incidents in Rochester. And we intended to engage community members in the research, which is why I'm doing this presentation today. And I also began my project with a presentation to a community board as well. So what I did in my project was I investigated the associations between redlining and critical health outcomes like smoking and lung cancer incidents, which hasn't been extensively studied before. And we were assessing the often overlooked history of persistent poverty in Rochester, which remains a pressing issue today. And this approach kind of shifts the focus from a general examination of race and ethnicity to a more targeted investigation of systemic and modifiable factors, which has the potential to advance equity by addressing the root causes and providing insights for policy and intervention. So the way we conducted this project was we started with performing a spatial overlay of census tract data with the HOLC grade. And you can see on this HOLC redlining map, the red areas were described as C, and then as it gets closer to green, it goes to B, and the dark green would be A. So I calculated the proportion of each tract by the grade, and I found that limited area was covered by a grade of D in Rochester specifically. So what we did was we combined the grades of A and B and C and D into yes or no variables, corresponding to having at least some area covered by A or B or by C or D. So if some area was covered, that variable would be yes, and if not, then no. And then we also looked at socioeconomic status covariates, including income, poverty, education, and insurance status, and I transformed them into variables of very low, low, medium, and high. And I actually found that high percentages or areas with high percentages of uninsured people and high percentages of people with less than a high school education was associated with less lung cancer. And the way I rationalized this was that like these are the groups of people who don't have access to regular primary care. So it's possible that even though these groups do still have a high prevalence of lung cancer, it's just not being captured. And then we estimated a linear model predicting smoking prevalence with the HOLC grades, and then a linear model predicting lung cancer incidence with HOLC grades while controlling for those socioeconomic status covariates I mentioned earlier. So what we found was that having at least some portion of a census tract covered by a CRD redlining grade was associated with a higher lung cancer incidence compared to having only A or B grades in the area, even when controlling for smoking, poverty, income, education, and insurance status. Similarly, C or D grades were also associated with a higher prevalence of smoking, and A or B was actually associated with a lower prevalence of smoking. And we also found that there was a moderate correlation between median household income and the percentage of tract coverage by grade of A, which shows how these socioeconomic covariates do vary by HOLC grade. And for further research, or what I want to look into further as I continue to work on this project, is environmental factors. So I want my models to control for air pollution, radon exposure, and things like that, and see how those affect smoking and lung cancer. And one more thing, I just want to acknowledge and thank the Institute for Human Health and Environmental Exploration for supporting this project. And that's it. Thank you. I will hand it off to Angela now.
Angela, you're muted. There you go.
Thank you. You'd think I'd get used to the Zoom platform, but clearly not. So again, my name is Angela Ganella, and I am the Lung Cancer Community Navigator Manager at Go-To for Lung Cancer. So I am kind of switching gears a little bit and going to talk about Go-To for Lung Cancer and some of the resources we have for both patients and providers. For those of you not familiar with Go-To, Go-To is the result of the Bonnie Alderio Foundation and the Lung Cancer Alliance, and they merged in 2020 to become Go-To for Lung Cancer. So right here, I'm going to highlight our website, which is goto.org, and we have various resources that are patient-facing as well as for providers. Resources on what is lung cancer, early detection, treatments and side effects, all for the patients and very much in language that is very easily digestible. At our organization, we have a lot of different branches, and one of it is patient support services. So as it sounds, patient support services provides services for patients and their families and caregivers. Some of those services that we offer are a helpline, and that can be reached via a phone number and our email, which is support@goto.org. We also have a phone buddy peer-to-peer support program, so connecting people with similar diagnoses to them to be able to provide mutual support. Another element that our patient support services team puts on is our lung cancer living room. So it's in person and live streamed. This is not local. It's actually based in in California, but it is live streamed on YouTube monthly. And we do have an upcoming presentation on the 19th about shared decision making and second options. And so again, those are reoccurring every month and highlighting patient services, their resources, and highlighting physicians that are experts in their field. We also have various educational tools for patients and providers to utilize. We have a storefront, store.goto.org, and all of our lung cancer educational materials can be ordered and shipped completely for free and at no cost to whoever is ordering them. So we have various offices ordering large quantities. Again, all of those have space on them to be co-branded if that's something that's of interest. But again, very much in language that's easily digestible, from what is lung cancer screening, why to quit smoking, to after diagnosis and talking about different types of nodules. And so I, again, recommend taking a look at some of those resources that are really great tools to be able to have in offices or for even individual patients to download on their own or order for themselves. We also have a patient screening education video. And again, I just wanted to highlight a lot of different things that Go-To offers, given that this is a very diverse crowd and different audiences here, just highlighting a lot of different things that might be helpful when it comes to lung cancer and lung cancer screening. So this is a very short video that we have that that highlights the complexities of lung cancer screening and really normalizes what that is. I think there's a large misunderstanding about what lung cancer screening entails and who is eligible. And so this is a great patient-facing video that is really great for providers to use in an office setting or clinic setting to really understand and help patients understand the benefits of low-dose CT for lung cancer screening. We also have a website dedicated just to healthcare professionals. So our hcp.goto.org website has resources specific to providers to be able to provide education and resources and tools to help them grow their understanding and help them elevate their practice. One of the elements on our healthcare provider website is our Global Knowledge Center for Lung Cancer. Within we call it our GKC, there are various training modules, educational videos, webinars that are downloaded, some of which do provide CEUs to be able to further education when it comes to lung cancer screening. These are more for a provider-facing audience or navigators. But again, a great space for providers to be able to further educate themselves. We also have a private community space for our centers of excellence, which I'll get into later about who our centers of excellence are. That is a community space for them to engage with one another. Every year we host a lung cancer navigator program, and so we offer 10 CEU credits for that, and it's held in person annually to really educate navigators. And we use the term navigators loosely. Some of them are community health workers, some of them are nurses, but we host them in a didactic workshop for them to further their work as a navigator in the lung cancer space. Lung cancer is becoming more popular as far as lung cancer screening with a lot of the policies that are coming through from CMS. And so really advancing the education for the navigators is a huge focus from GoTo for lung cancer. As I highlighted before, we have a Centers of Excellence program. And so I know Wilmot has their COE program, but it's a little bit different. The acronym is different. So these are highlighting centers of excellence when it comes to lung cancer and lung cancer screening. And so it's a really easy process to become a COE, but this is our map of all the different COEs across the country. We are not local just to New York. And that list is ever growing and expanding, especially with some of the regional work that I am doing in New York State. Again, another branch of our organization is our science and research team. So we have 4 divisions at GoTo that cross-collaborate. So we have different kind of areas of focus, including clinical research, community engaged research, survey research, precision medicine, and navigation. So again, a lot of great resources when it comes to science and research that we have collaborated with on various facilities across the country, as I mentioned. This is a highlight of some of the different research studies that we are currently engaged in, including one on inherited risk and discovering the origin of lung cancer in families, Ready Lung, which is looking at reducing lung cancer disparities for African Americans. And again, a lot of great resources. And if anybody has questions specific to research, they can always contact me. I'll have my contact information at the end. So now getting back to what I am doing specifically. So I am part of our Excellence in Healthcare Delivery team at GoTo. And what I am working on is a New York State demonstration project. And so the main aim of that project is to leverage partnerships and resources between GoTo and the lung cancer screening community and the regional efforts that are already taking place. And really the goal of this project is to increase access to lung cancer screening, increase the uptake of lung cancer screening, implement high quality early detection and lung cancer screening programs in marginalized and impoverished communities in New York State, and just develop these strategies to serve as a template to expand beyond this small community in upstate New York, and really try to improve the lung cancer screening rates and hopefully stage shifts so people are getting diagnosed earlier when it's more treatable and survivable. As it's been highlighted in the previous presentations, lung cancer is the leading cause of cancer deaths in the United States, and more people die of lung cancer than colon, breast, and prostate combined. So again, really wanting to change the outlook of what it looks like to be diagnosed with lung cancer, and that stems from early screening. So some of this regional work that I've been doing is leveraging New York State established community members and networks to activate the lung cancer screening community, including lung cancer screening providers and regional community leaders. So I've been convening and collaborating with various individuals, and this focus has been in Western New York primarily, but then we are shifting it towards Rochester and Syracuse, New York, before hopefully moving some of these efforts downstate. And so I've been meeting with community leaders, primary care providers, and really trying to understand what are their barriers to lung cancer screening. And through these structured interviews with primary care, we've noticed that there's a huge knowledge gap. So as we move into this next phase, we are developing microeducation, highlighting some of the topics that have emerged as barriers, and creating these micro-learning modules for primary care providers and navigators in the primary care setting, because that's how patients are getting screened, through referrals from primary care. And they're really at the heart of identifying these patients that are eligible. And as we prepare primary care providers and educate them on lung cancer screening, also educating the community so that they also know who is eligible for services for lung cancer. So I know I talked very fast. I wanted to make sure I covered all the different things that GoTo has to offer. And I really only scratched the surface. There are very restrictive eligibility for lung cancer screening. I'm not sure how many of you are in specifically the lung cancer space who are in attendance today. But if you're not aware, the U.S. Preventive Task Force, the eligibility guidelines for them is anybody 50 through 80, CMS it's 50 through 77, current tobacco use or quit within 15 years, and a 20-pack year history. So that is the current eligibility guidelines. And in addition to that, there's some other barriers in addition to lung cancer screening that have to take place, including shared decision-making conversation and smoking cessation. So a lot of different elements when it comes to lung cancer and lung cancer screening. So again, a lot to cover, but I know I had 10 minutes, so I just wanted to kind of scratch the surface about some of the resources GoTo has to offer.
Well, thank you to all of our presenters today. We covered quite the gamut of different aspects in terms of lung cancer screening, from things that might affect and improve treatment options for lung cancer to reasons for increased incidence in certain populations to resources that have been available. So I think have covered everything, and we've got some questions that have already been coming in. But please remember, if you have any questions, you can enter them at any time into our Q&A box. If we do not get to your questions before the end of our webinar today, we will make sure that we provide answers in the follow-up email that you will receive. So make sure that you put them in there, even if you don't think that there'll be time. So let's just jump in right away. And I'm very glad to see there are a lot of questions today about language access, which is wonderful. So first, we'll go to you, Angela. Do you have resources for the deaf population?
So I can't necessarily speak to resources for the deaf population. I do know that for that lung cancer screening video, there is closed captioning available. And I did see another question about Spanish as well. So that there is an opportunity for Spanish translation on that video. And in our GoTo storefront, those resources that are patient facing, those are available in English, and there are majority of them also available in Spanish.
Thank you. And well, with that, it says, are there any other languages that are offered? I know that that's always a tough one because Spanish is much more prevalent than other languages. Do you have any resources with other languages that you know of?
Yeah, at GoTo specifically, I'd have to look to see what other translations are available for some of those documents. And I think as needs grow, I think that's something that our team can definitely look at. We have a team dedicated to looking at those educational materials and understanding where there are gaps in what we have to offer.
Thank you for that. Juliana, I think this one is for you. So what are the next steps for your research?
Okay, can you hear me, right? Thank you for the question. We have like a long road ahead of us. I think at this point, we are trying to find in our models like efficient ways to restore the clock function. As I mentioned, they're not very efficient drugs for that at this point. They're not in clinical use at all, but even like in a research level, like these things are coming out with time. But at research levels, you don't have like very specific drugs that modulate the proteins from the circadian clock. So it's something that we have to invest some time doing that. And yeah, I think it's probably the next step. And the other part of the project that I didn't show you very much about it is that we are trying to understand the reason why, for example, in lung cancer, like mouse models, when the animals are like show circadian disruption, the cancer proliferates like fast. We're trying to understand like mechanistically why this is happening. So how circadian disruption is actually contributing to tumor initiation and formation. And we think that maybe we have some data showing that maybe circadian rhythms might be implicated in loss of differentiation of these cells. So these cells, like cancer cells, they usually forget a little bit about from then where they came from. So they lose some markers of the tissue or the specific cells that they come from. And we think the circadian clock might be regulating that. And also some other aspect is that immune response is very important to fight cancer. So, and we think when the circadian clock is disrupted, circadian rhythms are disrupted, it has been shown by other groups that might impact on how your immune systems like fight against cancer. And this is also might be a mechanism by which circadian disruption is promoting cancer, make our immune system less effective in removing and killing these cancer cells. So this is like ongoing research. We still will have like a long road ahead of us, but we are working like in multiple fronts.
Thank you for that. The next one I think also is a little bit more in your direction. I think this might be a little difficult though. What is the timeline for getting this research into human clinical trials? So I guess more of the question is, I mean, you work in basic research. You're in the lab, you're
Basic
working with
research.
mice. Yes. So with that, when you're doing your research, how long does it usually take before this is something that would reach even touching the human population in a clinical trial?
So this can take, I cannot precise, but this can take sometimes many years, or depending on the field, a decade or so. So it depends a lot. At this point, I think drugs are a limitation. We don't have like good drugs to control the clock. However, I can highlight some like directions that circadian research is going like now in terms of like application in the clinics. I don't know if you ever like heard about chronotherapy. Like the idea is that if we have circadian rhythms, our biological functions are like oscillating throughout the day. So the the goal of chronotherapy is that maybe there is like a best time of the day to deliver that drug where it will produce either a more efficient response or less toxicity for the patient. So I think chronotherapy is maybe the most applicable like side of chronobiology, the research of circadian rhythms. And there are some studies like showing, for example, that the time of the day that you deliver immunotherapy, for example, matters. So you have if you deliver the therapy during the day, it seems to be more or less efficient than when we deliver the therapy like later in the day. So for chemotherapy, are also some studies showing that depending on the time of the day that you deliver the therapy, this can be more or less toxic for the patient. So I think this is chronotherapy is probably like right now the most applicable therapy related to circadian rhythms. But these drugs that modulate in the clock, they're still in research, so it's not applicable right away.
So a very long time.
Yeah, it can take some time. It depends. Like,
Well, that's good too, because then it makes sure that it's safe to be brought to
yeah,
humans before
exactly.
it's tested. So that's good to know. Um, let's switch over to a question, Angela, that I think you can answer. So this is a really good question, actually, Joyce. Um, do you know of any plans in the future to have any sort of lung cancer screening for those exposed to secondhand smoke for decades? And Joyce is a fantastic um, community member. She goes out and works with a lot of different communities in the Rochester area. And she says that she spoke to a senior woman who both parents were heavy smokers as well as her husband. So she paid for a screening herself and was able to get it and proved that she had a nodule. But do you know of anything that's going on to get that kind of thing covered?
Yeah, so I can't speak to that specifically. I do know that we have an arm of organization that is focused on policy and looking at expanding the eligibility as a whole to look at um, different environmental exposures, secondhand smoke. So currently they are not within the eligibility criteria. I don't know what currently that timeline looks like, but I know we do have a dedicated team that works on policy initiatives, including expanding for secondhand exposure, as well as looking at policies for the veteran community, as well as women who are starting to get higher rates of incidence of lung cancer. So, but I don't know what that timeline looks like.
Right. Thank you for that. So, yep, Joyce, it does seem that they can get the screenings. It just might have to be out of pocket rather than being covered for the time being, at least. Okay, we only have a couple more minutes. I want to try to get to as many of these as we can. There's a lot of questions, which I'm really glad to see about the deaf population and about actually just access to data. For instance, on like the incidence and mortality for lung cancer, if there's research that's being done specific to the deaf population. And I'm not sure if any of us here have the answers to those questions. No? Yeah.
I do not know.
Okay, so I will bring these questions back to the team. I do know that we have several different researchers throughout the building. We also have the National Institute for Deaf Health, I believe, that is located here at U of R. So I will reach out and see if I can find some answers. I know that one of the biggest difficulties is that's not listed on the census as a question as to whether or not someone is deaf, which makes it very hard then to make that kind of correlation. But those are really good questions. So I'll see if I can find some information and include it in the follow-up email. Otherwise, I will let you know we can't find that answer. But at least it's a place to start looking. Okay. We will also, okay, time is up. So we will also be including as much of the presentations as we can. If there are any links or if there are more information, it will be sent out in the follow-up email. So thank you to our presenters. Thank you to all of you for being here. And a special thank you to our interpreters for ensuring that this webinar has been accessible to our deaf community members. So if you are attempting to get CME credit, please make sure that you fill out your post survey. Even if you're not, please fill it out and just let us know what you thought so that we can make sure that we're providing content that you are interested in. So early next week, you will be receiving the email with the link. Thank you very much for attending, and we will see you next time.
Thank you very much.